is talk a little bit about TMS. And we've been talking about TMS, but not really describing it, so I want to go over it a little bit. So TMS, or transcranial magnetic stimulation, is a whole different way of treating the brain. We have three ways to treat the brain. We can do therapy, which is talk therapy. We can do medications, which are basically the chemicals that go all over your brain, all over your body, and hopefully get to where we want to go. Or we can directly stimulate parts of the brain, TMS being the latest and most frequently used method to do that. And the reason TMS is now coming to the surface is because finally we are beginning to understand the brain circuits that contribute to our thought patterns. So you will soon hear from Dr. Kangalaro that this technology called functional brain imaging, which is fMRI or PET, will allow us, and we have Dr. Marino here who can speak about it too, allow us to see what we're thinking. Okay, so for the first time in the history of psychiatry, we can capture thoughts. It's like trying to capture lightning in a bottle. What you're essentially seeing is the brain circuits that get activated when we have certain thoughts. And we can read those thoughts and essentially say what somebody's thinking. In fact, it's one of the best lie detectors. As you might imagine, when we tell the truth, it activates a few areas of the brain. When we lie, it activates many areas, because it's a much more complicated action. So while it's a very sophisticated action, it may not always be the best thing in a social world. We can see if somebody is a psychopath, for example. So if you show somebody a picture, let's say, yesterday was, or 2 days ago was, the 4th anniversary of the Newtown school massacre. We show the pictures of those children to, I'm sure, all of us, it'll activate our amygdala. But if you show it to somebody who lacks empathy, which is the definition of psychopath, it'll activate its prefrontal cortex because they're more curious. So on the surface, they may be crying, they may even be able to increase their heart rate, but on the inside, we can see exactly whether they lack empathy or not, and therefore determine who is associated, going to be a psychopath or who isn't. So that's, it's an amazing technology, and you'll hear soon about it. But one of the areas, obviously, that did most research is really understanding the circuits involved in depression. So in depression, what we typically see is anyone who's depressed, the left prefrontal cortex is the area that is out here, which is important for enjoyment and pleasure and flexibility in our thinking and motivation, tends to be underactive. And areas that it controls that are in deeper regions of the brain that contribute to anxiety and agitation and insomnia tend to become overactive. So there's almost a signature circuit that we typically associate with depression. I remember a long time ago, a patient of mine asked, do psychiatrists have x-rays? And now we technically do. We just have to do the research. Because right now, psychiatry is simply, our diagnostic, the way we sort of diagnose is based on symptoms, right? Whereas in virtually every other field of medicine, they have tests. Hopefully in the future, we'll have a test. Just to give you an analogy, when someone comes and they say they're depressed, we ask for all the different symptoms. You just heard Dr. Copeland talk about mixed features and anxiety, etc. Those are all symptoms. We really need a test. An analogy is if you go in to a doctor with the flu, the doctor sits there and says, do you have a fever? What color is your snot? Is it green? Is it yellow? Is it, do you have a headache? And then they decide, okay, based on the symptom cluster you're giving, what antibiotic you're going to get. Only about a third of the patients will get better. That's what's happening in psychiatry. We base our diagnosis based on symptoms. We give them an antidepressant, hope we can get lucky, and about a third of the patients get better. In fact, placebo also works a third of the time. So some of the initial studies where they compared placebo to antidepressants showed that it didn't really separate. It was only when you look at more severe depressions did antidepressants separate. But now with this technology, we can actually get an X-ray of the brain and see if somebody's depressed. So in the future, when somebody comes in, tells you they're depressed, we'll probably order an fMRI. We'll know what kind of depression they have, whether it's bipolar, whether it's something else, what subtype. And then then the question is, can we treat it? Can we target that area? Now TMS is the first treatment in the history of psychiatry that can actually target the brain circuits involved in depression. What it is it's a magnetic coil. Let's see if I have the slides here. Okay. So it is a magnetic coil that generates a pulse. It's an electromagnetic coil that generates a magnetic pulse that can directly target a specific area of the brain. So we can do fast TMS and stimulate a part of the brain that's underactive, such as in depression, or we can give slow TMS and suppress the area of the brain that's overactive, such as if somebody's hearing voices, and if you find the area that's lighting up when they're hearing voices, we can use slow TMS, and then actually in real time we can suppress the hearing of those voices. Now, if you keep stimulating over and over and over again through a process called brain plasticity, those changes become permanent. Because the brain can learn something. That's really how memory works, right? With memory, you just activate the same brain circuits over and over again, and it consolidates the recollection of the memory, and that remains permanent. Unlike the spinal cords don't learn, brain cells learn. So if you stimulate the left front part of the brain over and over again, we do it, each session is about 30 minutes, we do it 5 days a week. Usually in about 3 to 4 weeks, people start feeling better. In about 5 to 6 weeks, they get 100% better. Then once you stop the treatment, unlike with antidepressants, with TMS, the benefits are sustained because you're really creating a brain circuit that is sustained. Now, about a third of the people might relapse, in which case they need to come back for more treatment. And about 25 to 30% of patients may not respond to TMS because perhaps we need to treat a different area. So in the future, we would do a functional brain scan and see exactly which area we need to treat, and then using something called neuronavigation, we can target the area to treat, and we may even have a close to 80-90% response. So because of this, because TMS is very precise. Now, just to add, TMS, a lot of people think, oh, TMS is like electroshock therapy or radiation. It's not. They're not shocking the brain. This is not ECT where you're going to have memory problems, etc. It's magnetic waves that are directly targeting one area. It's not, there's no radiation involved. This is not like a CT scan or X-ray. This is like an MRI. And it's, in fact, MRI is a slow wave magnetic wave, so it's pretty safe. It's safer in theory than even a cell phone. Cell phones are fast wave magnetic wave. So from a safety standpoint, TMS is superior to virtually anything we treat. And because they're not putting anything in the body, obviously there are no side effects like you might see with medications. So what we are doing is we're specifically targeting the part of the brain that is involved in depression. And this is sort of a brain scan, which is somehow neuronetics when they put their coil in there, but it was a different coil that was actually used. So this is a very interesting sort of system where you have an MRI scanner, fMRI scanner, and you have a magnetic coil inside that. And when you treat, I think there's a pointer here, right?
Yeah.
Yeah, the center.
That was on
It's right in the center.
The circle on the center.
This one? Oh,
It takes a lot of IQ to figure out.
My neurogenesis is down because of mine, but which actually kills new neurons. So what you see is you stimulate the part of the brain that is underactive, and then that can in turn activate other parts of the brain that are deeper as a part of the depression circuit. So this is in real time, where a patient is sitting inside an MRI scanner getting treated. These devices are very expensive. They cost like 10 million. There are only like 3 in the world. But in a perfect world, that's what we need to really see. So we're targeting part of the brain that's underactive in depression, and we're stimulating it.
But what's the end of those studies? Like, are we talking like one subject?
This is one subject, just one person in the
As an
scan.
example,
Yeah.
do we have a study of a whole number of patients?
That's going to be the next talk.
Oh, okay.
This is sort of setup. So because we target this area, it's very safe. We're not targeting. We're not doing radiation, and you don't have systemic side effects, like weight gain, sexual side effects, a lot of those issues that you see with antidepressants. Even the risk of something like seizures is very low. There's been only 8 seizures in the last 1.5 million TMS sessions, whereas in some of the antidepressants, the risk of seizures could be as high as 1 in 100. And so this is a very safe treatment. We've treated people, while it's FDA approved for depression, we've gone off label and treated people as young as 7 years old, and we've also treated pregnant women because we find that this is safer than those kind of treatments. The only people who can't have TMS are people with magnetic metal implants in the head. So in the studies, and as Darby mentioned, there are actually 4 studies, and I was the first author in the international guidelines that came out a few months ago. I should have put that slide up here. But anyway, bottom line is, in the studies with TMS, what we find is that it's more efficacious than antidepressants. And it makes sense because we're really targeting the part of the brain. So when we do what's called a meta-analysis where we take all the studies of TMS and compare to placebo, we see that it's a very, very strong effect, a very powerful effect. If you look at a similar meta-analysis, there's a big one done with antidepressants, they don't see that power. In fact, in the initial meta-analysis of antidepressants versus placebo, there was no statistical separation until they took more significantly depressed patients in. So it's a very powerful treatment. In fact, in these studies, what we've looked at are people who failed 3 to 4 antidepressants, and then they've done TMS. And if usually, once you try 3 to 4 antidepressants and you fail to respond, the chances of you responding to the 5th antidepressant in data coming from what's called the STAR-D trial is less than 5%. Whereas with TMS, we're getting a 60 to 65% response rate, TMS alone. And we've done open label data with antidepressants and TMS where people have failed antidepressants. But we keep them on it because we know it creates a platform on which TMS can be more effective. And those numbers can be as high as 75 or 80% in open label studies, so they have not been studied as carefully. But the numbers are very, very impressive. So think about it. People, by the time they try 3 or 4 antidepressants, they've been, most of the time you would wait months, maybe years before you see a doctor. You're suffering. And then you try medications for 3-4 years and you're suffering, and all of a sudden, with TMS, you could get about, a large fraction of those patients better. They start feeling better as early as 3 weeks, and they usually get completely better in about 6 weeks. So it's a pretty remarkable treatment, and it makes sense, right? Because this is where the science proves the clinical data. We're targeting the circuit, so therefore people are getting better, more effectively, faster, the benefits are more durable, and obviously it's much safer and better tolerated. So it's a real game changer in the field of psychiatry. There was an article in the New York Times or the Wall Street Journal actually claiming that in the last 70 years, psychiatry has not come up with anything new. And obviously they didn't know about TMS. Because, so they should go back and do their homework. What they're saying is that with antidepressants, you can try 3 different flavors of the same thing, and you're really, getting, a few percentage of patients better when you try different things. This is the first time we've come up with something very different that can make such a big impact.